are on time.
Perfect. Excellent. Well, can you hear me well?
Yes. So welcome everyone to our multimodality imaging lecture series. It's a great honor today to have with us Jorge Gonzalez, who will be talking about multimodality imaging of thoracic aortic aneurysms, a general cardiology perspective. As a brief introduction, Jorge is the director of advanced cardiovascular imaging at the Scripps Clinic in San Diego, where he actually created the hypertrophic cardiomyopathy and the aorta clinic. And these clinics, and he runs these clinics, and they have been recognized as center of excellence in the country. And these clinics are very important. There are not many of these clinics in the country. And he runs, I believe the only one in San Diego. Dr. Gonzalez earned his medical degree for Central University in Venezuela. He did his training in Philadelphia, not too far from where I trained. He was at Temple University. And then he did his imaging fellowship at the NIH at University of Virginia under the mentorship of Chris Kramer, who gave us the lecture here of hypertrophic cardiomyopathy, and Michael Salerno. So it's a great pleasure to have you here. I think we're very excited about your lecture, so thank you very much.
Thank you, Leandro. Thank you for the nice introduction. Primarily, today to start, I just want to make sure that we discuss the background. Definitely, I'm a general cardiologist, but I'm also an imager, especially CT and MRI, of course. But one of the approaches today is just to kind of dissect a topic that seems to be a very difficult topic from the general cardiology perspective. At times, not in management, but in imaging when it involves those two modalities, and particularly CT and MRI. And so I'm going to try to dissect that in a simple way that brings some concepts, knowing that this is a very extensive topic. I mean, there are topics that we can discuss here for hours, decades, for weekends for a symposium. And it has been researched for decades. And, many other centers have been spearheading this in the East Coast and West Coast, and in the South, primarily Stanford, Yale, and Texas. And there are great symposiums in there and very good resources for you guys, primarily because the guidelines are kind of like outdated, and it seems that no specialty besides the surgical portion of these topics are the ones who are very extensively covered by guidelines. Disclosures are none. Again, very big difference between acute in-hospital management versus outpatient. Mostly, the management also can be divided between thoracic and abdominal. Huge difference between the two. Syndromics and non-syndromic aortic aneurysms, we can take an entire day just to go through those two and the differences that carries, not only in terms of the diagnosis, but most importantly, management. Also acute and chronic aneurysms, how you follow this in the outpatient setting versus in the hospital. The imaging modality of choice from all the systems that we use in cardiology, especially in advanced imaging. And also an entire topic can be discussed in a symposium just for surgical repair. Today, I want to make sure that you understand we're focusing on those mostly thoracic aneurysms, outpatient stable patients, and syndromic versus non-syndromic are covered mostly in most of the outpatient clinics when you refer a patient. And the long-term follow-up of the thoracic aneurysm is one of the most crucial aspects in that general cardiologists should learn, because we are the ones who usually carry the load in following these patients. The imaging modality schedule is kind of like the part I will cover in the second part of the talk. Just as a background, because always we have to talk about prevalence, that we know that the disease of the aorta and the branches is pretty common in the United States. It accounts for almost 50,000 deaths in the United States every year. The thoracic aortic aneurysms ranks in the top 20 of leading causes of mortality in this country. And it represents a major leading cause of death in people above the age of 65. Lethal thoracic dissections are often misdiagnosed as MIs or myocardial infarctions. And we know that those patients sometimes present with atypical symptoms, despite how many times they tell us in medical school that the chest pain radiated to the back and ripping kind of sensation. The more and more I do aorta the more I can see that the symptoms are usually not all of the time typical. Pretty famous diseases and pretty famous people have had and died from this disease, not only the thoracic, but also abdominal aortic aneurysm. We know that since the early 2000s has become more and more prevalent, the news about it and articles about it, because John Ritter from Three's company, he died, and there was a sad story back in the early 2003. And ended up being also at the end with a wrongful death lawsuit. And one of the biggest things that I carried from there was that they were claiming that the radiologists failed to detect a large aorta in a CT scan done previously. And that's usually one of the parts. It's not so much that the ER still remains one of the most litigious places for missing this kind of condition, especially in the top 5. But it's the part that sometimes we have scans that are not for aorta necessarily, and we sometimes forget to look at that as cardiologists, not just as radiologists, but as cardiologists, especially since nowadays in most programs like yours and mine, we try to teach the general fellows to be comfortable reading CT chest, not as a radiologist or cardiac imager, but at least to recognize a screening pathologies. They created a foundation afterwards to have helped the awareness of aortic pathologies, especially thoracic aortic aneurysms. Other famous people, if you continue looking in the literature, like Lucy Ball, she had a thoracic aortic aneurysm and had repair of that aneurysm. And then within a week, she died from rupture of a AAA. And the same thing for Albert Einstein, who also suffered a AAA. Very, very extensive in the literature, also in the news. You can see it every time there's a famous person. There's some articles. This is one of my favorite articles, was given to me by Mohit Bazin from Norfolk, Virginia, who's one of my mentors, which it basically tells you, like the way I call it and tell patients, is a medical orphan condition, because the surgeons usually are very good at treating it, thank God, because we have them, and that's usually a surgical repair. And they're usually very good at this, but that's usually what they like the most. And the way, for example, a cardiologist manage sometimes the blood pressure, but sometimes they don't have the training for CT and MRI to continue having a long-term longitudinal follow-up. And the radiologist, who's probably the best at detecting this, usually doesn't have an office for you to go and talk. And so usually very easy when people don't have it or have ectasia or a very small enlargement, as compared to people who have aneurysms. But the people in the middle, who are the ones who you are going to follow and you're going to see in the clinic in the long term, are the ones who usually are left with a lot of questions. And again, there's no medical specialty devoted to treating the body's largest artery. Just to start with the first imaging modality, X-rays usually are not very accurate. I mean, the widened mediastinum that we're all taught in medical school sometimes is useful if it's very obvious. But in those patients who have a small aneurysm or a petite body, sometimes, especially in the ER, it seems that every time there's a widened mediastinum, because the patients are in the bed towards the left or the right, crawling on their beds. So that if you have worked in an ER, how unreliable sometimes that sign is. As I said, the orthopathologists, we can spend here a week. And usually, most commonly associated is usually Marfan's from all these leads, the bicuspid aortic valve. And there are other ones that usually Turner syndrome is also common in some aorta clinics, of course, but also the other ones that are not that common, which is usually the vasculitis aortitis, or other part that we as cardiologists sometimes don't encounter often. And again, we try to cover today more generic and not going, but all the type of pathologies have a different and particularly cutoff for surgery, especially, for example, in patients with Turner's or Lewis-Dietz syndrome, as we know, or Ehlers-Danlos vascular type. Some of those patients we tend to bring earlier for the operating room. And there are also familiar thoracic aortic aneurysm for what we do genetic testing, that some of those genetic testing, if they are positive, that we also tend to go below the 5.5 threshold we usually bring patients. The most common questions I get always from patients, from primary care physicians and referring cardiologists is, what is the normal aorta size? Is it dilated? And if so, if it's aneurysmal? Well, to start, the biggest thing is that not all the patients are the same. Age, gender, BSA, and BMI matters. I think we are realizing, because when we see the difference, the striking difference, like in the image, or basketball players or athletes compared to regular people, who are, don't have the same aortas. And so when you talk about an aorta of 42 millimeters in a person like this in the picture, it might not be that much, but if you do 42 and someone like the doctors around him, then there will be a complete different aspect of it. And so the parameters and the databases are different from each modality. The multimodality imaging is not well taught during our training in general cardiology, at least a decade ago when I was training. It has changed over time, but it still needs a lot of improvement and a lot of support to try to get more advanced imaging fellowships in the future. There are not enough specialists, and the lack of interest in the field dominated mostly by thoracic and vascular surgeons and radiologists. And usually the cardiologists have been steering away from getting involved, because usually symposiums and conferences and ACC, when you go, all we talk is about surgical repair. There has been written extensively about the aortic size, and you can start seeing by early articles in the 2000s, in which every year or every 2 years, you see articles trying to come up with normal limits by age. And as you can see how in this paper, it was published in JACC Imaging, you can see how even depending on what type of modality you use, there's a difference in terms of the cutoffs. And so based on this cutoff study, for example, just the ascending aorta dimensional diameter was 33 plus minus 4. And depending also in what area you are doing the cut or where you're reading from, and if you're using CT, echo, or MRI, this makes it very difficult for people to remember. And so there are normograms. That article, for example, has a beautiful page with the normograms, what they think, especially based on age, because you know that the aorta enlarges in patients after the age of 50 or 65. And there's usually some enlargement component, also patients who could have hypertension are also based on age and gender. And so they also have a formula trying to figure out the normal, which complicates sometimes matters. When you go to each guidelines of each society of imaging, also they have their own normograms and their normal values, which is sometimes very difficult to remember when you're doing multimodality imaging. The CT Society also has their own. It's a very limited study, and we use this here at Scripps Clinic. And many radiologists use references like this to try to come up with what normal will be. We know that there's an article, recently last year, published, in which we know that also those population-based risk factors trying to come up with the likelihood of having a dilatation, and their formulas and also normograms for it. We know if you have a dilatation, you are more likely to have another dilatation. That's why we tend to do the images of the entire chest, abdomen, and pelvis, especially when you're doing the first diagnosis or the first time you're doing the imaging of this patient. And so it's usually more proximal to the aneurysm. So if you have a patient with ascending aortic dilatation, you better look proximal to that area, because the most likely next area where a patient has the enlargement will be at the arch, or if it's in the arch in the descending or the ascending for the patient. So it's a good article, but mostly importantly in this article, it shows that I thought it was pretty interesting. It's a very nice editorial written about it, trying to come up with a good database of almost 15,000 patients about what normal is. And they also provide their normals and their estimations. And they also have even formulas that you can see and you can use if females or males, which again, for the management of every daily life and general cardiology is very complicated. But those centers that have aorta, you have different ways to kind of like come up with what normal is. If I can recommend you 2 articles for you to read about the topic today, because again, it's a very extensive and we have limited time here together, will be these 2 articles probably are the most important articles I've read contemporarily in the last 5 years. And I really use them on a daily basis, especially when I teach the fellows or I teach some colleagues or I do any local conferences, because they talk about basically some of the aspects of each of our techniques and what we face as limitations for each of them, because all of them have limitations. Important concepts is I think very important is when you come up with something normal that you're using, like for us in this case is the CT data, and we have the normal values. we have the difference between ectation aneurysm, and ectation aneurysm is important. By definition, always conventionally, a dilatation is anything that refers to a dimension that is greater than 95th percentile for the normal person, age, sex, and body size. So if you have this as a range of 28.2 in men in the mid-descending portion, that will correspond to around 34 millimeters. And the ectasia represents a diffuse dilatation of the aorta less than 50% of the normal diameter. So in this patient, for example, if you have the normal person based on this paper, 28.2 plus those standard deviation, the ectasia represents probably an enlargement less than 42 millimeters. And so you have other ways to also look at that data. If the patient has a 45 millimeters, it will be an aneurysm, or you can also do it by standard deviation. So that's why an aortic aneurysm is defined as a localized dilatation of the aorta that's more than 50% of predicted, which is the ratio observed, that number that you obtain, divided by the expected being more than 1.5. You can do those math in any patient you have based on whatever normogram you're using. And that's where we usually tell, or if it's an ectation aneurysmal dilatation. The paper that I mentioned to you from 2020 that I just mentioned that you should read as a complement to this talk, that mentions usually that's why the number of 40 strikes in your head for most people. When is anything the cutoff is 40 or above, you think about it, because not many aortas are above 40. So that means that is, regardless of BSA, is usually abnormal. The type of aneurysms, also remember, they're, most importantly for you to remember are these two in the outpatient clinic. Saccular aneurysms are less common, but fusiform. The saccular is a typical outpouching, very small like this. And the fusiform is like a tubular dilatation. And this is very well used by our radiologists, the radiology community who uses these terms. So be comfortable, because you will see it very often. The imaging, you can use anything from the advanced imaging. We can use echo, we can use MRI without contrast, MRI with contrast, CT with contrast, and CT without the contrast. They all have their particular peculiarities, that they all have their differences and technical aspects from each of them. From the aortic pathologists, this is also a very important paper that basically over the years, we have always seen the difference between the echo and the CT and MRI always being very like a big difference among them when you tell a number. So this, in the last probably 5 years, there's a lot of research that it seems that the consensus has been that when you do the leading edge to leading edge technique on an echocardiogram, you're more able to match the CT and MRI inner to inner edge. And that is still, by doing that, as shown in the picture on the middle and left, you are going to be probably more consistent with your labs. This, we implemented it here when I started my aorta clinic. It was done before my time in 2016, before the inner to inner. The guidelines were this around 2015 when they changed in the ASC. And then we implemented, because when you start an aorta program and you follow the measurements as CT and MRI dictates, you're going to see a humongous disparity between the two, and that's what usually is going to lead for you to change it. But by now in 2022, most places most likely are doing this by ASC convention. But this is part of that historic momentum that we had like 5-6 years ago about aorta. Even if you do that, sometimes I just give you the caveat that sometimes you're going to still find differences, as written here in that article in the Journal of the ASC, in which you still is not going to be perfect, it's not going to be matched. And so that brings another topic, and I can tell you that it's one of my passions here, is that I recommend later on, if you have an aorta clinic, is that sometimes I have seen differences in which if I use, instead of the inner to inner, and I use a little bit of the outer to outer of the patient, I usually match very, very well the echo. Again, that's an observation. It's my personal experience so far. Myself, since I started here, I made the surgeons usually measure the aorta from the outer to outer, and I have a database from those measurements in which I can compare each of my modalities to try to refine tune and see where the difference came from. Primarily because when they tell you that 5.5 is the threshold for surgery, as we all know by boards and studying med school and in training, that 5.5, you see the articles where that came from, And originally in the 1970s and 1980s, it was mostly because the surgeon was measuring with a caliper. And those measurements usually is the outer to outer. But again, still today, we do the inner to inner, but it's something that you can then fine tune and see yourself in your own scanners when you tune the modalities. Transthoracic echocardiogram, as we know, it's a very widely used. It has no radiation. It's a great tool. It's cheaper than the CT and MRA. The patient tolerates it, and it's pretty, what I think is more standardized in the United States because it has been around for a long time, and cardiologists, all of us, are comfortable, and that's why the transthoracic, it has all those advantages. Every time you're trying to build a CT and MRI program, not in a place like yours, but let's say in a place like mine when I was here, it takes a long time to build protocols and train people. It's very easy to do that in any hospital in the US in terms of the transthoracics, because we are, again, as a society, own that modality and is widely used in our world. Remember, it's not the most accurate testing, and I'll show you one of the pitfalls that we have on echo. There's a lot about the annulus that you can then discuss. There's even conferences about this. And we learned this when we were learning about TAVR more than a decade ago, in which, depending on the angle of the sonographer, you can see when you go to the sinus to the commissure or from sinus to sinus, you have different sizes. We know that there's some conventions about changing this, and some places like Cleveland Clinic, that's what the measurements they use, which is sinus to sinus. And the reason for that, sometimes, we'll touch base later. The issue is that it depends also on the angle in which the sonographer will obtain that picture. And again, that's the major limitation of echo. And so it all depends on the fancy, beautiful pictures you can obtain, not because your sonographer or your machine, but it also depends on the patient's body habits. If it's very bony, like a skinny person or obese person, it's all very different. And as you know, as cardiologists, it depends and varies from place to place. You can have patients like in the left, which is upper notch on the sternal, on the intercostal second space, in which you can see a lot of the ascending aorta. It's difficult still sometimes if the patient has a fat pad to know where that line of border of the aorta is, and if the patient has any plaque or artifacts, around that site specifically, or reverberation artifacts, where that border is, it makes it challenging. Sometimes can be as easy as this picture, in which clearly you can see the leading edge and the leading edge, and there's no plaque in between and no significant differences. So it all depends on that, and we'll encourage cardiologists always to look at where the measurement was. But however, one of the biggest things is never assume that, just because, which is, I think, is one of the biggest things I see on echo as cardiologists, is that just because you're seeing this part, clearly you can see here as the valve, the sinus of Valsalva, part of the ST junction, but you don't see the ascending portion. You don't assume that this is not dilated, because as you can see, this is the patient's same scan a week later, and the patient definitely had an aneurysm. And so just because you cannot get the images, don't just assume because you see the picture and it's normal, at least by your eyes, even though this doesn't seem to be normal, the dilatation of the sinus of Valsalva. But it's pretty common when you see this part that you don't see the ascending portion well on transthoracics. Again, the measurements are pretty difficult. A very nice article, from that article in 2020 from the Yale group. It shows you how to do the measurements on that area of the sinus of Valsalva. But one of the pitfalls on here on echo is that you're only seeing two of those sinus of Valsalva, not the third. And you will see, as when you do aorta, that is sometimes tricky. This is a patient with, for example, bicuspid valve Sievers type 0. The annulus is oval and more difficult sometimes to measure, and sometimes part of the raphe from the other sinus, it's creating a thickening, or there's calcification from the aortic valve, and you're going to use this or what leading edge you're going to use. Sometimes when you're off axis, you can have this, what they call the flat sinus artifact, in which you're not able to grasp the real size, and it's very nicely pictured in this article, which you can see on the ASC guidelines too. They discuss about it, in which if you're off angle, you will have different measures, like on this picture and this red arrow. And this is an example. I tell you, if you're in these views, you're only mostly getting part of this area okay, you're going to get a different size if you get this size, because most bicuspid valve, not so much type 0 sievers, but the type 1s usually have an dysmorphic valve in which one of the annulus is bigger than the other one, and it tends to be the one that is not connected with the raphe. And so that, just take those caveats that there are like some weaknesses, but again, it's the best screening test we have. And I encourage you to always be the first modality, especially in those patients also with bicuspid valves. The CTA, I would say, is the gold standard of imaging in aorta, at least to give you with contrast, to give you the definition of what the size, really truly size of the aorta is. And it has the greatest sensitivity and specificity. Depending upon your scanner, that's the issue. If you have a 64 slide CT scanner, but if you have a contemporary scanner, 320 slides, or very modern scanner capable of doing advanced CT also for coronaries, you can build protocols, and that's what the importance of having the combination between radiologists and cardiologists, to have built protocols to have a very low radiation exposure. For us, for example, we created a low KBP program in which we protocols, like along with radiologists and the PhDs that run our safety part of the radiation in the hospital. And we don't pass more than 100 DLP, 120 DLP on each of them, which is less than probably 2.2 millisieverts. So it's very low now in radiation as compared to the old data that the guidelines sometimes mention. Again, the CTA, most important is the measurement perpendicular to the axis of the aorta. And that you can achieve that by using softwares in which you can use on planes, the 3 orthogonal planes, and change the angles. You can see this if you do aorta outside in your institution. A lot of this, people measuring the 3D reconstruction and the axial images. This is mostly abdominals, but you can see that this is a measurement on a patient, done on the arch. This is a measurement also done on a coronal and a sagittal patients. We do not measure here, and this is not where the guidelines or ever in an advanced imaging fellowship they'll teach you. You don't ever mention in any tricks or reconstruction from MRIs or 3D from CT. Those places are not the place for you to measure. Always you're measuring perpendicular to the axis, and you see the aorta well, and there's a real barrel of the aorta looking at you perpendicular from that axis. The controversies of the sinus to commissure versus to sinus is still even mentioned in the Editorials article that I mentioned to you. It's a seminal paper review that actually helped me propagate what I was talking about when I came here in 2016, and validated what I saw during my fellowship and learned during my advanced fellowships. Is that this also in many other places they continue doing the commissure to sinus, but in other places like the Cleveland Clinic, they're doing commissure to commissure. And it has a very good explanation of why, because then you can find in this paper, when you are doing the maximum sizing of the CT, you can see how the area of that valve is basically corresponds to the sinus to sinus. And that's usually the maximum size of that aorta. Again, there's a lot of research about this. You can see here in future directions of papers that come out this year and the last 2 years that they're trying also to do the area and see if they can come up, instead of the measurements by the sinus to sinus, we can come up measurements of the of area instead, like that we do for ascending aorta. For techniques of CT, remember, is always ECG gated. We should do the thinnest millimeter cut possible, less than 1 millimeter. You can see sometimes scans and acquisitions of reconstructions where they measure the aorta done at 3 millimeters. Not ideal. It should be the thinnest. The sinotubular junction, the non-gated studies, if you don't gate them, you're going to have this sometimes, the ghosting artifact. Or you may have, besides ghosting artifacts, you may have this, like where they try to measure the aorta and you can clearly see the aortic valve open. And there is a difference here, mostly because obviously this is not the aorta, this is the aorta moving, and that's why we gate the studies. But in this case, the reason also systole and diastole, not so much for the sinus of Valsalva, but also for the ascending portion and the other parts of the aorta, more proximal to the heart. We know that systole and diastole, there's a big difference. If you ever read an MRI, sit down with Leandro or Aldo in your institution, and you will see that when you do an axial cut of the chest of the all the way to the top of the aorta, and you can do it just for training, you can see how the aorta actually expands. If you were measuring that in systole and diastole, you can see how there is a difference, usually of 1 to 2 millimeters, or even more further, depending on what portion you're measuring. So we always measure in diastole. That's why we gauge the studies, and that's why it's very important. From the MRA perspective, we have also another technique that is very useful. It doesn't involve any type of radiation whatsoever, and it's very accurate as well. Not available in all hospitals, and sometimes a little bit more complicated than it seems, but it's not as complicated as a cardiac MRI. It also gives you very different images in which you can observe and measure. You can have the bright blood and the dark blood images, contrast, non-contrast, and you can play with them and see if they match. They're very, very well match with the CT, and again, it's not radiation, and sometimes the issue is cost. The other beautiful part of MRI that's coming up with the last decade, hopefully this continues to move forward in the field of 4D flow, is that in a research recently published in JACC Imaging with a nice editorial for my compatriot, Dr. Michelena, in which they say, they show what we have been researching for a long time about the shear stress of the wall, and trying to see if there is, as Dr. Michelena says, the Holy Grail of trying to find out predictors besides the typical sizing of who to operate. And that leads me to this topic, in which the 5.5 that we're taught in medical school or in training usually is not the greatest. It's a great measurement for most overall people average, but always keep in mind that a lot of dissections and complications happen, as you can see in the graphic, and I would recommend to read this paper, even though it's old. That a lot of those complications happen even in non-syndromic aortic aneurysms. And that's what we're trying to avoid. That's the whole reason of having an aortic clinic. One of my favorites to use, even though it has been taught mostly in Marfan patients and also discussed in a lot of bicuspid patients, but I tend to use it in almost every single patient. And I use it mostly because this only was published for ascending aortic aneurysm, was the aortic size index, as many surgeons they use. The surgeons I use, especially here in the West Coast when I refer, that's they pay attention to this number, and it's usually the aortic diameter in centimeters divided by the BSA. And so it has a nice table. Anything in the pink area is low risk, and the moderate is light green, and the dark green is severe. Almost no one is going to wait until here. And so always the controversy is when you're in this line or in the green zone. We know that if that number is about 275, that's when I usually start referring and involve the surgeon. And that's why most patients are in this area, and that's why they belong to you as a cardiologist. And the surgeons usually most of the time in that area, they're not going to be involved. And not only that, the most usually common involvement of a surgeon, at least in our institution before I came here, was the measurement was 4.7, and now it's 5.3. Is there any change in that? 5 millimeters in a year, as you know, is an indication for surgery. So that used to be the most common consultation for CT surgeons. And, that's one of the useful parts of the aortic clinic, because then cardiologists can decide if really was not an imaging problem, because that's what we always face, which is the disparity between the modalities. And if you truly believe this would have real change, which the surgeon, again, is not the one who manages all these advanced imaging modalities. And that's why sometimes it's just the team approach what makes the big change for patients with these conditions. You can make your own table based on the data, whatever you manage. In this case, for example, this is an example in Excel spreadsheet, very simple. I created. I use it every day in my clinic. And basically, I plug the numbers depending if whatever I got the number from in kilos or pounds and converted. And then I get a BSA number. It's plugged into the normal or the measurements of the patient. And then I have the difference based on the normal standard deviation, if it's male or female. It shows you normalized and then the standard deviation. I use a lot the standard deviation to know where I am, knowing that anything above 5 standard deviation usually is in the realm of aneurysm, and anything below that is usually ectasia. And then I spit out the ASI in this area and give a risk. And so all my patients get this. I have this in all my clinics. And you can do it. It's pretty straightforward. It's just a formula. There are actually calculators online, and you can do it yourself. The only caveat is that you cannot use that in patients who have a big BMI. So they don't mention what the cutoff, but usually about 35. Definitely, I don't use it because, as you can see, it's not going to show you the reality when you use BSA. Because if the BSA is bigger, it's going to completely change the outcome of the risk of the patient. So it's usually going to lower it. And so the more body surface area, the patient has a BMI of 40, it looks great. And so that's why they created this, especially in bicuspid patients. And you can see this Benson formula, very useful. We base that on the CT, mostly on the patient where you get the first image. And it's in those patients, again, I tend to use in people with BMI about 30. And then you get that area of the aorta on this plane, and then divide that by the height. So it doesn't play any role there, the weight of the patient, the BSA. And so if that number is above 10, you're a higher risk, and then you can consider discussing with your surgeon. Again, the reporting, you should have very good protocols that they're everywhere in every guidelines in the ATS, ASC, or in the CCT Society, in which all the segments, sinus above salva, ST junction, ascending aorta, and that's the way you should report it. Again, has been already over a decade placed in guidelines. When you do the reporting, you have all the segments also in your packs. You give a 3D reconstruction, which is very, very helpful, the rendering for showing patients. We tend to use this for giving the surgeon a roadmap of possible plaque where he's going to put his clamp to avoid a stroke. We have a CPR to make sure that there's no small dissections. It's kind of like a CPR of the aorta that moves, and you can see. And we have diagnosed dissections that were hidden in the typical axial images that you can miss. So it's very useful, this as well. We added to all the coronaries, since you're gating and most of them are evaluated at the diastolic phase. We actually, in the protocol, we make all the measurements of the root and the ascending aorta, primarily mostly because since you're going to use a lot of coronaries moving forward, thanks to the guideline change last year, you're going to have a lot of disparity. If you don't put that in your reports, people are going to look at that as, oh, there's a 5 millimeter change, 6 millimeter change. So we did this for consistency. We use the CT data, whatever you use, you're going to put it there as in your reports and packs. So that way people know this is the way we report it and what mean or averages of aorta we use for. Just to show you and to finalize, to have some time for questions, I'll bring some cases, very simple, just to bring home the point of what I'm trying to convey, and some examples of the use of those parameters that I just told you to kind of like have an idea of risk. This is a 72-year-old female with a prior history of hypertension, thoracic ascending aortic and ascending aneurysm. She was followed for years by an outside cardiologist. Previous measurements were 47 millimeters. So what happens often, and that's why I try to tell the fellows, you have to be comfortable to always open a CT of the chest and have an idea. The more you see, you don't even need to measure at glance. When you see the configuration of the chest and the area of the chest with the size of the aorta, that relationship in your eyes should just prompt you to measure, look for the measurements and see how they were measured. So a lot of radiologists, they will put in the key images on your packs where the measurements were. And that is important. If you see ever a measure done this way, you go back again and tell them to do it on the 3D, or yourself, if you're an imager, open it and get Leandro and Aldo and somebody in your radiology department and do it. The difference, even though it's a small, as you can see by the paper in 2020, the difference can matter, especially if you're following these patients. It does not matter for patients who are a normal size, and it does not matter, I mean, if the patient has an aneurysm of 6.5, is going to see the surgeon. But it matters, I tell you, for patients who are seeing you as a cardiologist, over long periods of time, because the changes matter in aorta. There's a big difference, and recent abstract shown in ACC very nicely in terms of what the difference of risk of ruptures is in patients who actually tend not to enlarge over the period of 5 years compared to those patients who do. Very, very nice abstract in ACC this year. Again, Because of that, it matters, and you have to at least feel comfortable with this. The same thing happens when you're reading CTs for the coronaries. You're seeing plaque, and you need to know what mild, moderate, and severe, because we don't have real measurements on CT chest. And so when patient, for example, gets admitted in the ER, I'm on call this weekend, I am going, everybody who has a CT of the chest prior, even a year before, it's a freebie for us. Not only to, that's why I highlighted that in the statistics from John Ritter when we started the talk, because it was missed 2 years before. It was an opportunity for you as a cardiologist not to miss it. And that's why I consider it very important. And so in this case, this was the measurement. This actually was redone by me, but it was said that the measurement was 47. Even if you redo the measurement in the sagittal, it was around 48.6. The patient ended up having, over time, dissection. There's a hematoma on the left side, dissection on the right side. I went to emergency surgery. When you look back some of the CTs, if you do it well under orthogonal reconstructions in all the planes, the aorta actually was around 53. I mean, in this case, I show you 52. They're a little bit below this. You can see there's none in the main pulmonary artery. If you go on the level of the main pulmonary artery, is 53. Does it matter? 53 would have not triggered immediately a surgeon referral, but you can see how if you use your numbers, and you can see if you use the 47 you had obtained in the sagittal pictures, if you go I just saw a lot of numbers, but just follow on the right side, you can see how it's a 517 standard deviation. So it's about 5, usually a good cutoff to say, this is abnormal. The BSA is a woman who is short. She's not very tall. And that ASA is hovering around the 2.75 ASI, which it would be a good time for you to bring the surgeon. It doesn't mean surgery. When you use for surgery, and again, this patient is not patient with Marfan's or aortic bicuspid valve, but it's something, it's tools, because we don't have, as that editorial from Dr. Michelena, we don't have the greatest tools, and we're still losing people. And so use all the tools that are available in the literature and try to help yourself, always involving the surgeon and the radiologist. As you can see on the right, if you were to measure that in orthogonal views and you plug it in with her data at 53 millimeters, you have an ASI of 3.07, which, at 3.07, I don't think there's many surgeons that would not take that person because she doesn't reach the 5.5, because her size is not the one that meets the usual conventional guidelines. And so if you even use the high ratio, the Benson formula, you can get even above 10. So you have multiple ways to say to a surgeon, listen, the measurement is this. Of course, and that was not just one measurement. There were measurements before, so could have been prevented. Yeah, it's nice to see it retrospectively, but it's something just as an example how some of these measurements and numbers matter. And number 2, this is just to show you that it's a 39-year-old person presented with chest pain to the ER. Widening of the mediastinum in this case helps, so don't disregard it. But don't always rely on it, because it usually happens in people who have an aorta that is pretty big. But in patients who have not such a large aorta, it's not going to be as reliable for you. Third case, a female with history of hypertension, 69 years of age, with high cholesterol obesity, presents totally to you asymptomatic for our cardiology office for one of my partners for primary prevention. He ordered a calcium score, and this is what they find. This is also an article earlier this year that shows data in which the calcium scores, they have a good incidence of this. And so it's also to think about that, especially if the patient doesn't have as striking as this, but as much as you screen, you will find the disease. And not necessarily family history would have worked. And again, this is all the things that patterns of patients who we're trying to find. But remember that some of the tests that you will order, in this case, a calcium score CT, this is probably a very common way to diagnose them. And I get a lot of referrals after abnormal calcium score, which are not just for coronaries. Now, I'm not saying that we should order this for aorta, but just pay attention also to your reports. Sometimes, this is overlooked if the aorta doesn't look that big, but if they have it and they report it, open the images and measure your aorta in your patients. And again, this was a picture of aorta. When you get the gated CT, the difference you can see, with contrast, and the 3D rendering patient went for surgery. In this case, I just show you, this is a 43-year-old male. Actually, I saw it yesterday. the PCP auscultated a murmur sent to me. Given his story and the characteristics of the murmur, it was clearly that most likely was going to have severe, bicuspid aortic valve. The symptoms of the patient. The patient had no symptoms whatsoever, but the part that I thought it was very curious was how the echo report says the ascending measurement was 40 and it's normal when indexed to patient's BSA. Again, just to show you how controversial it is sometimes, how, what data, what measurements are you using, what you're comparing to. When you put the perspective that it is a Sieverts type 0 valve, which is a little bit off axis, and the measurements were not done, it's not because they were not done properly, it's because it's difficult. And sometimes you have to play in different angles to see the real size of it. When we did the CT scan, the size, instead of being 40, was around 45 of the ST junction and 44 of the sinus. Again, a caveat that is not in the guidelines, but I tell you, again, another of my caveats that I tend to use, I always bring the short axis to recreate the pictures of the CT, and I do the measurements myself. Now you're going to ask me, well, what do you use? The outside of this edge or the inner of the inner? That's the part that is difficult. And so in some patients, not as thick as here, so you can use both, and whatever you use, you'll be in the right sense, but in this case, if you use the outer to this patient, you probably wouldn't get very close to the real size seen on the CT. My last case is a patient, 61-year-old woman who came to me because of Raynaud's and arm pain. And, she had a very severe case with the 4 or 5 fingers of her arm completely wide and usually very atypical. She had a prior history of a descending thoracic aortic aneurysm that it started as almost like an aortitis, and it was diagnosed at the time as a GCA. And this was left to her with a very heavily calcified area, and thinking that will follow over the years. But then this was the newest presentation over the last year. And then she ended up having a CT scan of the upper extremity and found almost complete occlusion of her axillary arteries. And just to show you, sometimes not all aortic diseases are the same. And you can have to think outside the box, even though every day what you see is bicuspid valve and familiar or non-familiar. But in this case, it was a Takayasu arteritis. So the imaging schedule, and again, this is my preference. Again, there's no guidelines for this, and they tell you what to use. This is my experience. Usually, what I use is the day 0 of the diagnosis, whatever modality you're going to use. I tend to use mostly CT. CT for me is the gold standard. I can see very well all the edges of the aorta. If it's a true aneurysm, I do day 0, 6, and 12 for the comparison to make sure there's not an enlargement happening, which will be an indication for surgery. I use also the initial data of the diagnosis and echo to make sure you don't have a bicuspid valve, and to see if there is matching between the two. And then as the time progresses and you feel comfortable knowing by CT that is not enlarging, then I switch to the combination of an echo and MRI. And so I tend to use this for later on, for just when I'm concerned or surgical decision is required. And then, or if the patient is, for example, like claustrophobic. But if not, I will use a combination MRI without contrast in the long term and echo, as long as they match. But you have to know that from the beginning. So first year, heavily on the CT and echo, to then later on yearly. And again, all depends on the size of the aneurysm. We're talking true aneurysms. Now, we're not talking about ectasia, which you can follow just over the years with an echo. Conclusions: the aorta imaging should be performed using echo, CT, and MRI. Orthogonal measurements should be made in all CT and MRI studies. The CT is, if it's utilized, should be always cardiac gated. Consistency in techniques and really is crucial for the long-term follow-up. The multidisciplinary team approach is the key to success. Cardiology, CT surgery, radiology, vascular surgery, primary care, rheumatologists, they're all part of that team. Each of them have a very unique experience and expertise. The aorta topic is extremely extensive, complicated, and it humbles me every day, even though I do it on a daily basis. And right now, it's almost half of my clinic of every day of my life is aortic patients. And so I tell you, it humbles me. Working with these people actually makes you a better doctor. And even the CT surgeons and vascular surgeons will thank you forever, because part of the imaging complexities, they are basically put to someone like you and the radiologist to create the protocols to help them make a better informed decision, because that's my job. My job is not to show you the 6.6 centimeters and do it well, because by even doing an x-ray, you can figure it out. Is those patients which are in the middle, to try to figure out those ones who are hiding, who have a risk factor that could be an early surgery or someone who you need to follow more often to be able to make a big change, in which usually CT surgeons are not involved that early because nobody refers them. Again, the blood pressure control and avoiding lifting heavy weights in aortic aneurysms is usually very crucial in our clinics, and we can even discuss about that topic in the future. The aortic size index and cross-sectional height ratio are useful tools in risk stratification. They're mostly, for the caveat that they're used for ascending aorta primarily, okay? And I know that is not for the rest of the segments. A lot of more research is coming, and this already ratios and formulas are old. There are newer formulas you can use, and you can find online whatever you use. It will be actually in addition to help you to make a decision. None of them are perfect. All of them that have caveats, but I think it's important to try to identify those patients who are at risk, and it will continue to evolve to try, and as Dr. Michelena says in the editorial this year, trying to find that Holy Grail, which is basically identify the people below that 5.5 to save their lives. Decision to send a patient for surgery is not as easy as choosing a 5.5 as a cutoff. And remember, that 5.5 is not for some of the syndromic patients I mentioned to you before, like Lewis-Doig syndromes and others. Thank you, and hopefully you can come to visit us in San Diego pretty soon.
Thank you so much, Jorge. That was a great presentation. I really enjoyed it. So please, everyone, if you have any questions in the QA, and we'll go through them. I really loved how you mentioned of how much data we have there from our patients, and how many times that's not reported or that's not being evaluated looking back at CTs. I think there's so much and so much prevention that we could do with that. I think as a first question, as a two questions. So for your patients, how do you treat them medically? What medications to use or targets? And when do you tell them? We were just talking about the Boston Marathon. What do you tell people that do professional sports or just recreational? What do you tell your patients?
Yeah, I mean, it's difficult. That's a topic that also has been researched extensively. There's an article this year about it in JACC, and it also very different school of thoughts. Like in the sports clinics, you can see that they don't tend to prohibit things to patients. They hate that, especially, for example, at UVA, when we had the hypertrophic cardiomyopathy clinic. I learned that with Dr. Battle and Dr. Kramer there. It's very difficult to tell an athlete not to exercise or not to do certain things. And I think we don't have enough data for that. The same thing happens with the conventional wisdom of the lifting weights and the aims or blood pressure. I think, all depends on what type of condition. I mean, if it's a Marfan's or it's a normal follow-up long-term stable aneurysm, and it's not that big, the standard deviation are not like the patients that I just showed you in 6 or 6.5. If it's something that the most I encounter every day, which is between 4.5 and 5.5, conventional wisdom will go for a blood pressure of like 120/80 and probably less. They're definitely avoiding 140s/90s and anything above. But I usually aim for 120/80 and probably less. The heart rate, usually we aim always less than 70. I think it's a conventional sometimes to try to we aim lower, we create bradycardia and other problems. So that's a cardiologist, I don't go that extensively. We're going always below 70. And in terms of exercises, I tell patients lifting heavy weights. I don't like the conventional thing that we tell them patients, and this is very common in old school to tell them kilos or pounds to lift. If you tell 50 pounds to guys I see who lift weight or used to lift weight or massive, linebacker, retired NFL players that I have, 50 pounds for them is nothing. And then for a petite woman, like the case of the dissection I show you, it is incredible weight. What matters is the mechanism of the Valsalva maneuver. So I tell them anything that makes them strain. So that's why I don't tell them too much of the weight and spend in terms of limits, but I tell them about that straining effort, which it will be something contraindicated. And I spend more time actually in terms of the limit weights. I spend more time in things that actually people don't think that automatically will put you in those categories of effort of lifting and Valsalva, which is, for example, when I came from the Boston Marathon last week, in the baggage claim, you grab a 50-pound thing and you're like pushing and things like that people are not aware. Constipation, and those things are the trivial things of daily life. That's where I spend the most time. But again, in terms of medications, also there's a lot of controversy of medications of what to use. My good friend, who I used to refer tons of patients, and I think it's the greatest surgeon I ever worked for aorta, Dr. Craig Miller, who recently retired last year from Stanford. He used to be, and there's a lot of data behind that for the ACE inhibitors and ARBs. He used to be not that fond of the idea of leaving those patients on those drugs because some of the shear wall stress data and dissections. And so there's other people who will tend to use more of the beta blockers and of course, because they're using for the heart rate and also for dual action for the blood pressure, like carvedilol and amlodipine and other things. But again, how do you get to that goal? I would say that's what matters. And it's also individual by the patient. And in terms of exercise, I mean, running a marathon and out of shape and you're having a heart rate of 180 pounding on your aorta, probably not the greatest thing. So if the patient has a significant aorta size, those activities are usually, not advised and to try to avoid those very high heart rates, even when exercising. But I don't tend to prohibit, and I think we don't have big data for that.
Great, thank you very much. We have a question from Halim Shamsam. Hopefully I pronounced it properly. Thank you for the excellent presentation. What is the diameter by echo that should alert me to send patient for a CT? You mentioned the magic number of 4.
Yeah, the 40. I mean, I remember when I was training, it was 39, usually the cutoff in the old guidelines. And I think probably the issue is the CT. I don't like to order CT. There's no threshold for ordering CTs because if not, you can end up ordering CTs on everyone because most of the common things that you see is actually a 57, 62-year-old patient with hypertension and he has a 41 millimeter aorta. What matters is to use the normograms to say, is this a 41 millimeters? Is in a petite person who is 1.5 or 1.6, meaning 5 or 4.8 feet. That is different. That if you tell me it's a patient with 41, 42 millimeters aorta, and you are, 6'1". So it's always the context of the size of the patient more than that. But I would say 40 is the easiest to remember. That's what Dr. Eleftheriadis mentions in the paper in 2020 that I think was very helpful. A lot of the times, those papers, seminal papers that I always think that you guys should use in your centers to give to people who are in primary care and cardiology, because sometimes to talk about this topic, especially when it doesn't come from a surgeon, the people are like, well, how does he know about aorta? And so it gives the message come across. And he mentions there as the 40, kind of like around 40, in the low 40s, but 40 probably is a good number to you to look, because there are some times when an aorta is in the 40s, or the aortic root, or the ascending aorta, is usually you will capture more. But ordering a CT, I would say, depending on that context. If it's a patient with hypertension and by the height, that's just 2 to 3 to 4 standards deviation, I don't tend to use a CT. But again, it's very individual. But for you to pay attention and do calculations, our 40 is a great number to remember.
Great, thank you very much. Are you sending patients for 4D flow in MRI or not much?
We have it, the technique. We're getting a second scanner now and we're developing. But again, as I always say, even when I was training, and probably happened to you, every time I go to the CMR, I would say 50% of all the papers are about 4D flow. And I think so as of now, 4D flow, the biggest use is in congenital heart disease. And so for aorta, I think we have used it, but there's no good guidance on parameters that I should use to really go for it and say, listen, this patient has this problem and it's a higher risk. This paper that came out in March, that Michelena was made the editorial comment, is useful, but I have seen that kind of research in that topic I mean, for the last 10 years in meetings. And I think we have not answered that questions yet, but it's a good start. And I think the 4D flow has a lot to say in the future. And I probably will say that's the biggest use for MRI. Yeah. I mean, many patients are trying to also find if there is any inflammation. Remember I tried to do research with Chris Kramer about when I was interested in aorta during fellowship, about the thickness of the aorta to try to do mapping, like T21 and T1 mapping or T2 mapping, but the pixels is so thin, it's less than 2-3 pixels that it was impossible to do it. And I tried for a year, and with the PhD helps, and it was very difficult. And so that a lot of things that still are to come in the aorta. But I think the 4D flow is still, again, like it has been mostly research yet. Bright future, but still research.
Great, thank you. A question from Shashibala Soni asks when to intervene, in particular in a very challenging patients with Marfan and pregnancy.
Pregnancy is also another hot topic. I mean, pregnancy and itself is another conference. There is actually a paper also, again, came out, I think, with the last year that talks about the complications of surgery. Jack has done an amazing work. If you Google and Jack for the last 4 years, anything aortic aneurysm, you'll find an amazing array of updated topics in aorta, and New England Journal as well. But Jack, I think, is the best topic about this. And in pregnancy, in those patients, I usually have, so I would say to you, as I tell you when he humbles this to you, I have at least, and I work today, for example, I'm in a satellite clinic and I work with the OB/GYN doctors, and I get a lot of those patients. And I always end up calling OB people who are experts, and some of them I've reached out, and for example, at Brigham in Boston, because you want to have different opinions. And so sometimes in those patients with Marfan, it all depends. I mean, most of obese is really a Marfan patient and with an aortic aneurysm complex. As you know, they're not going to go through the regular delivery. They most likely are going to do C-section. In those patients that are challenging blood pressure, usually, if they have preeclampsia, you have to treat them very aggressively. But again, you're not going to have operating a patient of a thoracic aortic aneurysm at that time during pregnancy until the patient delivers. And so for those managements, all the management comes afterwards. In those patients, we do a lot of echo and an MRI. It's still doable. We try to avoid the CT for obvious reasons, for radiation exposure to the baby.
Okay, great. I think that was the last question. So thank you very much for an amazing lecture, and I definitely want to come visit very soon with that picture you put there.
Well, we would love to have you guys, and if you guys go to SCCT or SCMR next year is in San Diego, so you have a reason to come.
That sounds great. Thank you very much.